Hello guys, today we'll be discussing about pulseoxymetry, right? A very important and interesting topic. So, what is it? It's just an instrument or a modality for rapid, non-invasive and continuous estimation of peripheral oxygen saturation, right? Nothing else. It just measures the peripheral oxygen saturation in a rapid, non-invasive and continuous way. So, what is the working principle? It is nothing but just the modification of Beer-Lambert's law. Important MCQ for NEET or NEET ACES examinations, right? So, what does it say? So, it simply says absorption of a light or a wavelength is directly proportional to the solute concentration and the path traveled through the medium. Let us consider an example. Here light is passing from point A to point B, and this is a medium and solute particles are there which will absorb the light which is passing from point A to point B. So as per this principle, or as per this modified principle of Beer-Lambert law, the absorption or of the absorbance is directly proportional to the solute concentration and the path traveled, the length we can consider it L, right? Directly proportional to the path traveled through the medium, right? So basically, let us go back to physiology. We have our hemoglobin exists basically in two forms, taut or T form and relaxed. Hope you remember, relaxed form is the oxygenated one and the taut form is the deoxygenated one. So what happens when it is oxygenated? It will have higher and higher affinity for oxygen, right? And when it is deoxygenated, it will promote the release. Hope you remember the principle of cooperativity, right? And our normal adult hemoglobin having 2 alpha chain and 2 beta chain. Okay, so among these two major forms of hemoglobin, we need to estimate their relative concentration depending upon the absorption spectrum using two types of LED, right? So we'll take two light emitting diodes with two different wavelengths in which these two hemoglobin fraction will have maximal absorption, right? So that we can differentiate their relative concentration. So we take a red, I mean 660 nanometer wavelength, and infrared, it is 940 nanometer. So for infrared or 940 nanometer, the absorption spectrum, it is maximal for oxyhemoglobin. For deoxyhemoglobin, absorption is maximum for 660 nanometer, right? So what happens next? Using these two LED light which cross the medium, and a photo detector is there on the opposite end. In finger probe, or if we use a probe for ear, the photo detector is placed at opposite to the diode, but in forehead probe they are placed side by side, right? So what happens next? By using these two wavelength, 940 and 660 nanometer, we got different absorption spectrum for these two dominant hemoglobin molecules, right? Then we need to have the ratio of absorption of these two different wavelengths for the alternating and the non-alternating or the direct part. So what is alternating? So if we consider the blood flow and the tissue components of the finger, let us say this is the arterial waveform and this part is pulsatile. Some arterial part or arterial waveform part will be having non-pulsatile component. Then there must be having some venous component, and below that must be having some tissue component, right? This is venous and this is tissue component. So we need to estimate the absorption spectrum of this pulsatile component only, and these non-pulsatile components from the arterial blood, venous blood and the tissues needs to be adjusted against this pulsatile component, right? And this ratio or R value is incorporate in an algorithm, right? So respective R values are calculated and they are placed in an algorithm for respective SpO2 value, and this algorithm is stored in the microprocessor. So let us take an example in which we get a particular R value. Let us consider the R value for some particular wavelength is 1. Then it corresponds to a SpO2 value of around 85%. Okay, so similarly these studies were conducted in healthy patients and it is valid for saturation range of 70 to 100%. So when it goes below 70, its validity decreases, right? Some practitioners consider it to be less than 80. So with the value less than 80, the validity or the precision decreases, right? So what happens? These two LED, they synchronously on and off intermittently, permitting the calculation of absorption spectrum of these two hemoglobin molecule in a continuous manner and almost 30 times on and off per minute. Okay, so basically what does it measure? It simply measures the peripheral oxygen saturation of hemoglobin, nothing else, right? Only the oxygen saturation of hemoglobin is measured. So let us consider an example. In this patient is severely anemic, a HB value of 5.8, but still your oxygen saturation will be normal. It won't affect the oxygen saturation because oxygen is fully saturated in spite of a low HB. Also, it do not represent tissue oxygenation, right? Then the effect of nail polish. So interesting MCQ for NEET SS mostly. So which nail polish color having minimal effect on pulse oximetry values? So when we use a pulse oximeter on finger using a finger probe, so we need to consider these nail polish colors because they do have effect on the reading as they do interfere with the absorption spectrum, right? So in experimental models we have got black, green and blue. These three colors have maximal effect, so they decrease the measured SpO2. What much value do they affect? For black, it decreases by 3%. For green, it's about 5%. And for blue, it's about 6% decline in SpO2 value. Remember, black, green, blue, 3, 5, 6% respectively. So what about red color? It don't have that much of effect. Also, acrylic nail polish have minimal effect. So what needs to be done for smooth and better calculation? Just remove the nail paint. That's it. Some people say you can align the pulse oximetry 90° to the normal angle. You can get a proper reading. Simultaneously, you can change the side, like ear, or if you have a forehead probe, you can use that, or other finger without nail paint, right? So remember, then what happens when you have other hemoglobin molecules like carboxyhemoglobin and methemoglobin? They do affect the reading because they do have absorption spectra on the wavelengths we do use in the estimation, right? So what happens with carboxyhemoglobin? Mostly in carbon monoxide poisoning, it overestimates the normal value. So what happens? Carboxyhemoglobin has similar absorption spectrum as oxyhemoglobin. So it senses the carboxyhemoglobin as it is to be oxyhemoglobin. So it overestimates the value. And what happens with methemoglobin? In methemoglobin, as we had discussed in the basic principle, when we calculated the ratio, it comes out to be 1, which corresponds to a SpO2 value of 85%. This happens with severe methemoglobinemia, means meth hemoglobin percentage of more than 20. So more than 20% of methyl HB, you get a SpO2 value of 85. So below 20%, of met HB, what happens to the pulse oximetry value? SpO2 drops by half. That means if there is 15% of met hemoglobin, SpO2 value drops by 7 to 8%. Got it? So these things are important in your clinical scenario. Also, what needs to be done? So when you have 4 hemoglobin species like HB, oxyhemoglobin, carboxyhemoglobin and methemoglobin, you need to have co-oximetry in which more than 2 wavelengths are used and individual hemoglobin molecule concentrations can be estimated with this principle, right? Simple pulse oximetry do not help here. So what happens when there is a severe tricuspid regurgitation, or we can say conditions in which there is venous pulsation, because this pulse oximetry is designed to read the pulsatile component of the flow. So when the venous component becomes pulsatile, it reads that component also. So the SpO2 value shows a false decline. It has a false low value in severe tricuspid regurgitation. So we need to consider these parameters when evaluating these things clinically, right? So what happens when we interpret a pulse oximetry value? we need to consider the waveform. Typical waveform should be like this, with a diacritic notch systolic of stroke, right? So when we have a poor perfusion, cold, calm, hypothermia, patients on cardiopulmonary bypass, you have a waveform like this. This signifies poor perfusion, and you need to replace the probe on a warm or normal temperature finger, or you need to change the site, or you can go for an ABG, arterial blood gas, to estimate SaO2 and PaO2 for further decision making, right? So as we had already discussed, when SpO2 value decreases below 80%, its validity decreases, right? So when assessing clinically, we need to focus on the trend rather than the absolute value. Let us consider an example: a patient whose baseline SpO2 was 99%, and suddenly after a few hours you get a SpO2 value of 94%. It is definitely a concern for you, right? For this patient 1. So let us consider an example of patient 2, who is a known COPD, okay, and his baseline SpO2 was 93%. Now it's 92%. It do not have that much of concern for you, right? So while estimating these values, the trend is important, and on what clinical context you are estimating it is important, right? So for an AE COPD patient, acute exacerbation of COPD, 88 to 92% of SpO2 is fair enough. In fact, SpO2 value of more than 92% is dangerous. Why? It causes rise in PCO2. Why? Why more than 92% of saturation or hyperoxia in these patients cause hypercapnia? Let me know in the comment section the right answer. Right? Why SpO2 of more than 93% cause increase in PCO2 in AECOPD? So basically, what is the mechanism? 2 to 3 interesting mechanisms are there. We'll discuss. Right? So when we have a pregnant lady with say ARDS, what will be the target SpO2? You can target a value of more than 95%, which is normal in this patient. Right? A patient with carbon monoxide poisoning or air embolism, what should be the target SpO2? It's around 100%, for the obvious reason, right? So what happens when you have a premature infant? What is the target SpO2? It's around 90, will be fair enough. Hyperoxia hampers, right? So which equals to the PaO2 value of around 60 millimeter of mercury, right? So the target of such SpO2 is not fixed. It varies depending upon the clinical context. So the clinical context is important in order to interpret the result, right? So pulse oximetry must be interpreted with plethysmography. What is plethysmography? Pleth means volume change with pulsatile flow, right? So the absolute value, that means if it is written as 98%, it is valid only when the waveform is adequate or the waveform is proper, right? Even if the value is 92 or 88, it is valid only when the waveform is proper, right? But if the waveform is not proper, or there is some artifact like this, the validity of absolute SpO2 decreases. You cannot comment whether the 92% or the 98% value is accurate or not. You cannot comment. So proper waveform analysis is mandatory, right? So now we had discussed about pulse oximetry, co-oximetry, then functional SaO2 and fractional A2, right? Functional, that is oxyhemoglobin, as we have calculated among deoxy and oxy SV, right? Ratio of oxyhemoglobin among both the other two dominant species. For calculation of fractional, we need to consider all the four hemoglobin species in the denominator, right? Oxyhemoglobin divided by oxy, deoxy, carboxyhemoglobin and methemoglobin. It is also important as an MCQ in NEET, right?